Hello everyone, welcome to HIM 216. This is the third lecture for Chapter 10. In your textbook, we're on page 190. We're down at the bottom of the page, and we're going to talk about the sequencing of severe sepsis. In your book, it tells you that if severe sepsis is present on admission and it meets the definition of the principal diagnosis, then the underlying systemic infection should be sequenced as a principal diagnosis. Now remember that what that means is that sepsis should be sequenced as the principal diagnosis. I think that term is confusing. I think when they say the underlying systemic infection, I don't know why they just don't say the sepsis should be sequenced first. So remember that when we're sequencing sepsis and we're coding sepsis, if we do not know what the organism is, we choose the default code of A41.9. But if we know what the causative organism is, if they do a culture and they can identify the organism, then the sepsis code for that organism is sequenced first. Then we would go to severe sepsis, R65.20, and we would also code R65.20. Now, keep in mind that this code can never be sequenced first, and it tells you that on 191. A code from subcategory R65.2 can never be assigned as a principal diagnosis. So that code can never be a principal diagnosis. It always has to be a secondary diagnosis. Severe sepsis may be present on admission, but it might not be diagnosed or confirmed until a few days after admission. And so if it's not clear whether or not that sepsis was present on admission, then you query the provider. Typically, sepsis is present on admission, but sometimes, as I mentioned in the last lecture, the patient will have another condition. They'll have an organ failure or an organ dysfunction, and it may take them a couple days to determine that in fact the cause for the organ dysfunction was the sepsis. The sepsis was present on admission and should be the principal diagnosis code. So if we look at the example, in this example the patient was admitted with pneumonia due to Staph aureus. Several days after admission, the patient developed septic shock due to Staph aureus sepsis. So they have coded the pneumonia first, J15.211. Then they have coded the sepsis, Staph aureus, A41.01 as a secondary diagnosis. And then they have coded sepsis severe with septic shock, A65.21. And I would actually, unless it was very clear that the patient did not have sepsis on admission, I would generate a query, because typically if a patient comes in with staph pneumonia and 2 or 3 days later they diagnose sepsis, the patient had sepsis when they were admitted. Now, sepsis and severe sepsis with a localized infection. If the reason for admission is both sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis, the code for the underlying systemic infection, meaning the code for the sepsis, should be sequenced first, and then a code for that localized infection would be secondary. If the patient also has a severe sepsis, then you would be assigning a code from R65.2. So in this scenario, where the patient has pneumonia, sepsis, and severe sepsis, you've got 3 codes. The sepsis is going to be the first code. So we'd have A41.9, J18.9, and R65.20 in that type of scenario. If the patient's admitted with a localized infection such as pneumonia, and the sepsis or severe sepsis doesn't develop until after admission, then the local infection is sequenced first. And then you have the appropriate code for the sepsis or severe sepsis. And of course, that's assuming that someone hasn't generated a query to ask the physician if in fact the patient had the sepsis on admission. So on page 192 at the top of the page, the patient was admitted in acute respiratory failure due to Staph aureus pneumonia. The patient also presented with sepsis due to a Staph aureus infection associated with respiratory failure. Well, in this instance, we're going to code the Staph aureus sepsis as our principal diagnosis code, A41.01. Then we're coding the Staph aureus pneumonia, J15.211, and then the respiratory failure, J96.00, and we're also coding the severe sepsis, R65.20, for this patient because they have sepsis with respiratory failure, so that is severe sepsis. That meets the definition of severe sepsis. So you may want to take this example and put it on an index card just as an example of how to code this kind of scenario. Now let's talk about sepsis that is due to a post-procedural infection. Now, when we have post-procedural complications, the documentation is always, the coding is always based on the provider's documentation and the relationship between the infection and the procedure. We cannot assume that a patient who has surgery and then develops an infection actually has a post-procedural infection. The physician needs to document that. Now, when we have sepsis due to a post-procedural infection, let's look at how to code that. So let's go to sepsis. Sepsis post-procedural. Now, I'm going to show you this because this is an error in the classification system, and I've emailed folks about it. This says the code is T81.49. Well, when you go to when you click on that code in the tabular, it takes you to T81.4. And if you click on this code, you'll see there is not a T81.49. What we have to do is choose the appropriate 7th character for this code. And this is an initial encounter, so we have to use our X's to fill in. Those are placeholders. Remember, an X is a placeholder. And so we've got T81.4. We have to have a 7th character of A, so we have to put X's in the 5th and 6th positions to get our full 7th character code. So the code will actually be T81.4XXA. In this scenario, we have a use additional code to identify infection, use additional code to identify severe sepsis if applicable. We have excludes 1 and 2 notes, and when we go all the way up to the beginning of this category, we have instructional notes here as well, and information about the 7th character for this particular category. So when we have a post-procedural infection that's occurred and it's resulted in severe sepsis, the code for the complication, such as T81.4, infection following a procedure, and this is an O86.0, this is for obstetrics, and we will study that more in chapter when we're going over chapter 15. We're going over the obstetrics chapter. And then, because it's severe sepsis, we're also going to have the code R65.20. And then we would have the code for the systemic infection. And if we don't know, it would be A41.9. If the infection results in septic shock, then the code for the complication, such as T81.4, infection following procedure, should be coded first, followed by a code of T81.12 post-procedural septic shock, and then we would have the code for this systemic infection. If we look at shock, post-procedural, septic, T81.12, and again we would need the 7th character, so we would be using a placeholder of X and then A for initial encounter. So in our last example on page 192, the patient's admitted with severe sepsis secondary to non-infectious acute pancreatitis. And if we go to pancreatitis acute without necrosis or infection, we find that code K85.90. We verify it in the tabular. And then this patient has severe sepsis, so we would be doing severe sepsis R65.20. And okay. Now on the bottom of page 192, 7 and 8, we'll study those in those specific chapters. On the top of page 193, we're talking about MRSA. If a patient is diagnosed with an infection and it's due to, we call it MRSA, M-R-S-A, methicillin-resistant Staphylococcus aureus, and that infection has a combination code that includes the organism, we would assign the appropriate combination code. We would not assign a code, the code B95.62. MRSA as a cause of disease classified elsewhere as an additional code, because we're using a combination code that includes the MRSA, so we don't use an additional code for that organism. We also would not assign a code from category Z16.11 resistant to penicillin, because this is implied in that code. Now, if there is documentation of a current infection, such in your book gives examples like a wound infection or a UTI that is due to MRSA, and there is not a combination code that includes the organism, then we're going to assign the code for that condition, such as the UTI, and then we're going to assign a code B95.62. And that's the MRSA as the cause of a disease classified elsewhere. But we would not assign a code from Z16.11 because we're actually assigning a code for the MRSA. Now, there are patients, and actually my daughter is a coronary care ICU nurse, and she said that if you do a nose culture on anybody who works in a hospital, that they will be positive for MRSA. So we're probably, any of us who have worked in hospitals or worked around patients probably have it colonized. But there is a condition of colonization for MSSA and MRSA. It's called colonization or carriage, where you're a carrier of it. And, I don't know if you're familiar with it, but, hand washing is so important in facilities and masks and things like that. And it is in part to not only keep the caregivers from getting sick, but from them passing along organisms they may themselves have or that they may have picked up from other patients. And MRSA is one of those things. If we have a person that's described as being colonized or being a carrier, that means that MSSA or MRSA is present in or on the body without causing an illness. You may see documentation that that the MRSA screen is positive or the MRSA nasal swab is positive. And there is a code for that, the code Z22.322 for carrier or suspected carrier. And if we go to carrier, then we will see all of these different types of organisms that people can be carriers of. And so methicillin susceptible, methicillin resistant, Z22.322, and that's a carrier. And actually this category Z22 is a code for people who are carriers of infectious diseases. So we can see typhoid, we can see diphtheria, meningococci, staphylococci, methicillin susceptible, MSSA, MRSA, all of these. If you want to look down through here, just remember there is a category for someone who is a carrier. Now, a patient can have both a colonization, or they can be a carrier of MRSA, and they can also have an MRSA infection at the same time. So both of those codes can be assigned. And if we look at these examples, pneumonia due to MRSA, we've coded that several times. UTI, again, we're coding the UTI. We know the UTI does not have an organism code, so we have to have a code from one of those B carriers. And if we go to infection, Staphylococcus as cause of disease classified elsewhere, MRSA B95.62. And then a patient who's positive, nasal swab positive, that means they're a carrier, and of course then we would go to carrier in the index and find that Z22.322. Okay, so for this lecture on page 199, I want you to, in exercise 10.2, I want you to answer question number 13. And now I'm going to, I want to point out that the rest of this coding is fairly straightforward in this chapter. If you'll turn to pages 210 and 211, every chapter has this, and these are the Z codes that may be applicable to this particular chapter in ICD-10. And so when you'll see that there are a lot of encounter codes here. All of these resistance codes are listed here. Then we have exposure to, contact with, carrier codes. So it's always a good idea just to look through these, because these can be associated with the codes from this particular chapter in ICD-10. Of course, it's chapter 1 in ICD-10. Then on page 213 is for your homework. You are doing the odd-numbered questions 1 through 19. And I will tell you that questions 1, 3, and 5 all have one code. For question number 7, this has two codes because one of these is a procedure code in ICD-10 for isolation. And so that procedure code begins with an 8. Questions 9, 11, and 13, and 15 all have one code. Question 17 has 2 codes. And then question 19 has 2 codes. And I'm going to caution you with question 19, you need to go and look at table 10.1. Okay, so now let's talk about your workbook homework for chapter 10. And on page 47 in your workbook, you're going to be answering all of the glossary definition questions 1 through 6. And then you're going to be doing case scenarios 1, 3, 5, and 7. So let's talk about those. So question 1, the patient comes in, they have cough and malaise. They have a history of AIDS. They have previously had Candidal esophagitis. And they find that the patient now has community-acquired pneumonia. So you're going to have to use your AIDS coding guidelines to complete this question, and there are actually 2 answers for this question. Then for number 3, this patient comes in with urosepsis. They do blood and urine cultures, and they come back positive for E. coli. And the discharge summary says that this patient has a urinary tract infection with sepsis due to E. coli. Now there are 2 answers to this question, and so again you're going to be using your sepsis guidelines to answer that question. Number 5, the patient is positive for HIV. They're coming in with fever, malaise, cough. PCP pneumonia is suspected and then ruled out. So that means the patient didn't have it. The tests show that the patient's symptoms were due to mononucleosis. So again, you're going to have to use your HIV guidelines to code that. Then for number 7, an AIDS patient is hospitalized for PCP, pneumocystis catarrhinae pneumonia. And then during that hospitalization, they find that the patient has oral thrush and early signs of AIDS-related dementia. So again, you're going to use your HIV guidelines to code that. I want us to look at number 2 for a minute. The patient was admitted with fever, cough, and low blood pressure. They do a chest x-ray. It shows infiltrates, and the sputum culture is positive for MRSA. So the discharge summary says that the patient was admitted and given IV antibiotics for MRSA pneumonia. For this particular scenario, the only thing that we are coding, and this is not a homework question, I'm just going over these. The only thing we're coding is the MRSA pneumonia, because the fever, the cough, and the low blood pressure are all integral to this MRSA pneumonia. They are not coded. Let's look at number 4. The patient came in with severe diarrhea. The patient was also severely dehydrated, so she was given IV fluids to get her hydrated, and the physician suspected that the patient had gastroenteritis, and they did stool cultures, and they found that the patient had C. diff colitis. So Clostridium difficile is C. diff colitis. It is a very contagious. It can have terrible effects on a patient. And in this scenario, the Clostridium difficile is the principal diagnosis code. It is the reason that the patient had the severe diarrhea, so the severe diarrhea is not coded. The severe diarrhea caused the dehydration. Dehydration is coded. Diarrhea is a sign and symptom. Dehydration is not. Diarrhea is integral to C. diff. Dehydration is not. So now let's look at number 6. This is a 5-month-old former 30-week preemie infant that comes into ER with cough, fever, and wheezing. So they suspect an upper respiratory tract infection. And during the examination, the patient becomes hypoxic, so the patient's admitted, and then they determine that the child has croup due to RSV. The principal diagnosis for this is croup. What's causing the croup is the respiratory syndactyl virus. For this particular scenario, we have 4 codes. The croup is first, then we have the code for the RSV. We're also going to code the hypoxia. Even though that's a sign and symptom, we're going to go ahead and code that in this case. And then there is actually a code that reflects that an infant was born prematurely, and we would apply that in this case as well. All right, look at number 8. This is a patient with known AIDS. They come into the hospital complaining of back pain, and they determine that that patient has a herniated lumbar disc. So they give the patient something for pain and tell him to follow up with orthopedics. Now, in this particular example, we have 2 codes. The fact that this patient has AIDS and a herniated lumbar disc. A herniated lumbar disc is not integral to AIDS. It is an unrelated condition. So that herniated lumbar disc is sequenced first. And that code is M51.26. It's in your student resources. And then we're coding the AIDS, B20. Let's look at number 10. A college student comes to the ER with severe headache and fever. He's admitted to rule out meningitis. So they did a lumbar puncture, and they determined that the patient had aseptic meningitis, and he was treated with fluids and rest. So in this instance, the aseptic meningitis is the principal diagnosis. We don't code the headache or the fever. Those are integral to the meningitis, and then we're coding the lumbar puncture. So I hope the explanation of those even-numbered case scenarios helped you out. And in fact, you can go to the student resources and see the actual codes, but I wanted you to hear the rationale behind what we sequence as a principal diagnosis and then a secondary diagnosis. So with your AIDS and your HIV, remember that if the patient comes in with an AIDS-defining illness, AIDS, which is B20, is always sequenced first, and then the code for that secondary AIDS-related illness is sequenced second. If they're coming in with a condition that is not related to their AIDS, it is not an AIDS-defining illness, then that condition is sequenced first, and then we'll have a code B20 for the actual AIDS. If you have any questions, let me know, and that will conclude this 3rd lecture for Chapter 10, and this is the final lecture.